want to give you just a little bit of background on the event itself. So we started this virtual conference series back in December, and we'll be finishing it a couple of months from now, in a few months from now in July. So we do have a few events left in this series, but what we've been doing is we've been taking a couple of times a month, we've been taking an hour or two to discuss different strategies for improving access to mental health care in the United States, primarily. Each event has been focused on a different topic, a different strategy. So today, what we're going to be talking about is rethinking the nature of mental health conditions. In case you're a little unsure what the relevance of this might be to the topic of access, there are actually many ways that this topic relates to improving access to mental health care, but at a very kind of high level, we have arguably hyper-medicalized mental health conditions, and some would say over-pathologized what is essentially normal behavior. And in doing so, we created more people who feel they need treatment, right? Because if you are someone who is diagnosed with one of these DSM conditions, then the implication is that that's a condition that needs to get treated, right? And then the more people who are being driven to seek treatment, the more squeeze that puts on access. So, but there are many, many other ways that this medicalized notion of mental health problems creates access problems. And so we're going to be exploring those in a lot of detail today. If you have not registered for other events, make sure that you take a look at our registration link and see what's coming up. We do have several events left, like I was talking about earlier, that you'll be able to register for. We've got some great topics coming up. I'm going to put the registration link in the chat box in a moment. But other than that, I think we can go ahead and get things kicked off here. I'm going to introduce our first speaker. We have a couple, I mean, we could really not have better speakers today than the two people that we have. I'm so grateful to both Dr. Hofmann and Dr. Francis for talking with us today. So Dr. Hofmann's going to go first. Stefan Hofmann is an international expert on psychotherapy for emotional disorders. He is the Alexander von Humboldt Foundation Professor for Translational Clinical Psychology at the Department of Clinical Psychology at Philipps University of Marburg, Germany. He was born and raised in Germany. He studied psychology in Germany, but then he came to the U.S. in 1991, worked at Boston from 1996 to 2023, and then he went back to Germany. Prior to that, he was at SUNY Albany, and before that, he was at Stanford. He was president of ABCT, Association for Behavioral and Cognitive Therapies, from 2012 to 2013. He's been editor-in-chief of Cognitive Therapy and Research since 2012. He's been the recipient of many awards. He was an advisor to the DSM-5 development process. He's published more than 500 peer-reviewed journal articles. I'll say that one again, 520 books. So very prolific psychologist here, and including one of the best-selling psychopathology textbooks in the world. I could go on, but I'll leave it there so he has time to talk to you about all his good work. So again, thank you so much, Dr. Hofmann, and I'm going to let you take it away.
Thanks, Jeff.
And then we'll have Dr. Francis after you. Mm-hmm.
Thanks for having me. And pleasure to be here. Maybe can I ask already folks to mute their microphones, because I get some background which a little sort of paranoia kind of coming up. Great, thank you for doing that. So so just briefly, I'm going to discuss a new way of conceptualizing psychopathology and also therapy, which we've been calling process-based therapy. And a lot of what I'm discussing has been done in close collaboration with Steve Hayes. I should say that in advance. So brief disclosure. So clearly cognitive behavioral therapy is sort of contemporarily the first line treatment for virtually all mental disorders. I've had a great fortune to work with Tim Beck very closely, especially in his later stage in life, and published also one of these articles that sort of points to the breadth and of cognitive therapy, which is really has become a science in and of itself. That includes, the spins off a number of evidence-based pathology, psychopathology models, and obviously really good treatment approaches. So clearly CBT has been arguably the greatest advance in certainly in psychotherapy for the past 50 years or so. Yet I would say that currently we are in a crisis mode. We focus, despite our success, us meaning psychotherapists doing cognitive behavior therapy and also psychiatrists doing something similar, we are very much focused on sort of treating syndromes, treating mental disorders with specific protocols, with specific manuals. We have focused too little on the treatment change process. We really still, despite the fact that it works quite well, we really don't still understand well why those treatments work. What are the mediating variables? We have been focused on a very simplistic way of analyzing the data, and we have been using group level data to really understand the individual, which has not been overly successful. Also, to add to this crisis is that our treatments, despite the fact that it works quite well, they're actually not improving over the years. But they should. We are understanding more and more about the psychopathology, yet the treatment approaches are not improving. Let me just elaborate on that very last point. Sorry, could you please mute your microphone? Thank you. So we've been publishing meta-analyses over the years on examining cognitive behavioral therapy as compared to placebo intervention for the range of anxiety disorders. The first one was published in 2008, showing a really solid, robust effect. New studies obviously came on board, and we widened and reanalyzed the data in 2018, so just about 10 years later, and the effect sizes for some reason became weaker, which surprised me. And then most recently in 2023-24, we published another one with the newer studies with the effect sizes shrinking even more. So this is the 2008 study, solid, the blue bar, solid 0.7 plus effect size of cognitive behavioral therapy for treating anxiety disorders as compared to placebo conditions. This is any anxiety disorder was included. And then the orange bar showed the 2018 studies where the effect size shrunk. The number of studies improved, obviously, because more studies came on board. And then adding the 10 additional studies in 2022 showed even further weakening of the effects. If you're looking at that overall, and we are now in the midst of publishing that. So these are all studies, all randomized, placebo-controlled CBT trials for anxiety disorders. Excuse me, everybody. Can I please ask to mute your microphone? That would be greatly appreciated. Thank you. These are some 50 plus studies. We show a remarkable pattern, namely that the effect sizes over the years shrink by about 0.05 effect size points per year. These moderating effects of publication year, in fact, is significant. So the earlier studies are very robust and strong effects. The more recent studies, the effects become weaker and weaker. I think one of the problems is actually the DSM-5 and the ICD-11. It's not any different because CBT has further evolved into ever so specific treatment protocols focusing on those ever so specific treatment syndromes. And what I would argue today to you is that we're missing the person as a result of that. We're focusing on syndromes and we're kind of forgetting the person who is sitting in front of us. We're treating disorders, we're no longer treating individuals. And this, I believe, is the main result why our effects are not improving over the years. Over the years, we've been developing these ever so specific treatment manuals for very specific syndromes. All of these are CBT protocols. You do not need to read them. This is an expanding list of books, of manuals, and you can go to any publisher, into any library. You will find very specific books for treating CBT for specific disorders. Publishers have a series of those books, every single one of them. There are even treatments that have that started out as a generic treatment, such as ACT, has become wrapped up into this idea of focusing on syndromes. ACT for depression, ACT for chronic pain, ACT for anxiety disorder, ACT for panic. Then there's CBT, which started out as a CBT as a treatment. Beck never developed CBT for panic or for depression. Eventually it became such, but at the beginning it was simply CBT. And as a cognitive therapist, you're trained with Beck, you're not trained in a specific treatment for psychopathology, you're simply trained in therapy. Yet there's CBT for, you name it, CBT for anorexia nervosa, CBT for bulimia, CBT for GAD, CBT for depression, etc., etc., etc. This is not a useful state of affairs. Who cares about these many books? Are we training now technicians? Do we now want individuals to become hyper-focused on treating particular psychopathologies and not knowing how to treat another form of psychopathology? Who really are we going to continue with this? And this is the rhetorical question. The answer should be no. We are at a state where we need to rethink the way we've been doing clinical science. Interestingly, when you look at these treatment manuals, you find specific strategies that keep reoccurring. So despite the long list of treatment protocols that are ever evolving, we find a fairly small set of strategies that are used in virtually all of these treatments to some extent in different ways. Some are focusing more on some of these aspects, other treatment manuals are focusing less on others. This is not this is also, number one, it's not a complete set, and number two, this is not a set that I derive, but rather it's an inter-organizational task force that was done by Bob Klepek, a former president of ABCT. The charge was to identify competencies that all good clinicians should know in order to treat any person coming through the office, into the office. And this is the 12 or 13 or so different strategies that everybody should know. The task force thought contingency management, stimulus control, shaping, stress, self-management, arousal reduction, coping, emotional regulation, problem solving, exposure, behavioral activation, interpersonal skills, cognitive reappraisal, modifying core beliefs, cognitive diffusion, experiential acceptance, attention training, values, choice clarification, mindfulness practice, enhancing motivation, crisis management. Some of these are strategies, others focus more on processes, but if you know these things, how to deal with that and how to apply that to a given individual, then you should be a good clinician. RDoC, as you know, was an alternative to DSM, which was also highly critical. And Tom Insel was trying to sort of get toward a dimensional idea where you would, similar to, you avoid arbitrary cut points and rather kind of let the ideas to be guided by biological mechanisms. So mechanism aspect is sort of an overarching new development in the field, and processes and dimension and a dimensional approach in general. The early RDoC matrix looked like that has evolved over the years, but I thought there's something useful that came out of it. One is that there are different domains, that these were obviously expert groups that formed them. This is nothing in nature, set in nature, but negative valence system, positive valence system, cognitive system, systems of social processes and arousal and regulatory systems. So people can have problems in these different systems. One of the problem I see is that RDoC did not assume that these systems are interconnected, but they are obviously not. They are not independent systems. What I also would object is that the attempt to go after specific genes, molecules, and even cells that would underlie abnormalities or dysfunctions in these systems, that is highly unlikely that we'll ever find a molecule or a cell that, obviously, if you study oxytocin involved, sure, you might have an idea that this similar things could. But clearly, I would argue no, that humans are too complex to be reduced to single circuit cells. Also, what RDoC did not do is we did not get away from a basic latent disease model. Namely, the latent disease model simply states that we cannot measure depression, schizophrenia, generalized anxiety disorder directly. We don't have a test for it. We don't have a blood test. We don't have any other ways of getting a precise measure, such as what you would get with a COVID infection. You would have a clear test that tells you if somebody has COVID or not. Rather, you infer the existence of the disease based on the subjective report by the patient. So if a person says, I have problems sleeping, and I might have problems concentrating, and I might feel down on yourself, clinician might say, oh, you probably have depression. And other symptoms are all obviously overlapping. Sleep problems don't only happen in depression, it also happen in many other problems, such as generalized anxiety disorder. Yet we would assume that, there's a latent disease that we assume to exist, and that is the sort of the source of these syndromes or symptoms. And those overlapping symptoms are obviously comorbidity, which really shouldn't happen in the DSM because we assume these categories to be succinct and distinct. RDoC doesn't really get away from it. It simply replaces the latent disease with circuitry or cells or molecules. So here's now a novel, maybe not so novel idea anymore, but what if we those diseases, we're not saying that they don't exist, but they don't have to exist for us to treat the individual adequately. And what is really important is to understand the interrelationship, the functional connections between what we call symptoms or syndromes. So let's call the symptoms no longer symptoms, let's call them problems that a person has, such as sleep problems or feeling bad about yourself. Having these problems, they are interconnected. Problems such as not being able to sleep at night will obviously affect another problem the next day, such as, not being able to concentrate or even feeling bad about yourself. And if you target one, you will likely target another problem. These problems are interconnected. They form a network of problems. And this gets me to the idea of complex networks. A complex network is simply a functionally interconnected set of items complex networks are really in many fields you can observe them. Climate scientists utilize complex networks in order to predict and to understand global phenomena that are highly complex. The global market is an example of a complex network. The internet itself is the World Wide Web. We call it a web. Is a network. Genes, we know, also turn other genes on and off and form complex networks. And brain scientists have embraced network ideas when we studied connectivity of brain areas. And we know today that those connections are more have a more validity and more clinical value than any particular activation of a particular brain area, because all the brain is a highly interconnected system. So even if you assume the existence of latent diseases, it would be not meaningful to assume these symptoms to be independent. But the DSM assumes it, and the ICD assumes that these symptoms are independent. But Bob and Alice, let's say these are two individuals, different individuals with identical diagnosis, namely major depressive disorder and generalized anxiety disorder. You, put aside that you have hundreds, if not thousands, of different ways of having a depression, depending on which particular symptom you combine. But also here Alice, as an example, might feel depressed and will have cognitive problems, might feel suicidal, might have, as a result of that, sleep problems, might have concentration problems, then might feel irritable and feel anxious and feel uneven. For Alice, other symptoms or other problems are not central, such as she does not feel overly on edge, and so forth. In the case of Bob, he is struggling with weight problems, which causes him to feel have ruminative tendencies and also have sleep problems. But these sleep problems causes him to experience fatigue, which then leads to concentration problems and feeling on edge. And so if you treated now, let's say, Bob for suicidal ideation or suicidal thoughts, you would not get far with Bob. Bob would say, I'm not suicidal. I feel quite happy with my life otherwise. But in Alice's case, absolutely, it would make sense to target her suicidality, because the suicidality seems to be a fairly central component in her problem. And also, if you targeted other aspects in Alice, which would be relevant for Bob, you wouldn't. It would be a mismatch. So you can see that different individuals, despite the fact having identical diagnosis, the functionality of these problems are very different, and therefore in treatment you would approach that very different. I'm going to jump ahead for time reasons to another slide. That yet in psychotherapy, when we study treatment processes, we are very much in our world of linear mediation. This is the way we think about treatment processes. And I would argue this is very wrong. So we assume that there's one mediator that is supposed to cause the effect of the treatment on the outcome. And this is a typical mediation figure. Everybody has seen that. Now, as an example, there might be a person might experience a breakup and ruminates and has experiences low mood, and rumination might be, in this case, a partial mediator of the influence of breakup on low mood. But for any given individual, there might be other problems that cause the low mood that come in addition to the rumination, that might be much more relevant. These other more relevant nodes or problems are displayed here as loneliness and low self-esteem, as an example. So breakup may cause low mood, but also the breakup might trigger feelings of loneliness, which then are closely tied to his or her experience of low self-esteem, which form close connections, and they are highly connected to the low mood. So this is a very simplistic network now, where if you were to concentrate on rumination, because your treatment manual says you have to target rumination when after a person's breakup, you would miss the boat here, because the self-esteem and loneliness in this particular individual is considerably more important. Barron and Kinney came up with this idea of a linear model that I'm sorry, linear mediational model that we've been employing ever since, where we assume that there's one variable mediating the effect of the treatment on the outcome. But therapy is not due to one or even only or a few variables. Therapy is a highly complicated, complex mechanism. The variables rarely, if ever, only form linear relationships. They are rarely only unidirectional. Usually, often they are bidirectional, and the mediation results from groups of people do not necessarily, if ever, actually apply to a single individual. The average person doesn't exist. It's a fictitious statistical idea. There is no average. And I'm sure Dr. Francis will elaborate on that very issue. Yet we assume that treatment, the course of treatment looks like that. That's our basic assumption. We assume therapy should look like that, and everything is built around it. We live in linear la-la land, to cite Pearl Mackenzie. Yet when you look at an individual, things are more likely to go up and down, and sometimes there are dramatic improvements, and those dramatic improvements are often actually even significant because they predict something called a sudden gain, where something is important happening. This brings us back to network ideas, because this is very much a dynamic idea that that things do not change linearly. Things change catastrophically, non-linearly. Similar to a ball that occupies two points, they are called attractor states. The ball in attractor state 1 occupies a stable state, and it's very difficult to move that state. Let's call that stable state abnormal or disordered. It's very difficult to move this ball over to a tipping point to another stable state. The tipping point is on point 2, and the ball in point 3 is another stable state that might call it healthy or desirable state. So therapy is not a linear, unidirectional, posivariate, so a few variable explaining mechanism, but instead is a complex, multivariate, and dynamic process. That brings me to a new way of conceptualizing psychopathology. We think that psychopathology is a maladaptation to a given context, not an expression of a latent disease. Therapy, in turn, is a way of changing a network from maladaptive, from one stable state to another stable state to be adaptive. We build treatment by combining evidence-based components to fit a particular individual, similar to bricks that we put together to form any structure we envision, such as walls or bridges or houses, etc. So in a way, we're going back to the origin, to Gordon Paul, who was formulated in '69. We need to understand what treatment by whom is most effective for this individual with that specific problem, under which set of circumstances, and how does it come about. That goes toward processes, and process broadly defined, not just mechanistically, univariately defined. We expand this idea and say we need to understand those core biopsychosocial processes, and biology is obviously very important, but it's not the only thing that matters. Also psychology, sociology matters, etc. Those processes, those we need to target to understand how we can move this individual from a maladaptive to an adaptive state. We focus on those processes of change that and the desirable outcome is whatever the client and the patient wants to go to. This is not simply a reduction in symptoms as defined by the DSM. We define maladaptation, psychopathology, as maladaptation due to unhealthy variation, selection, and retention in a given context. These are the principles of adaptation. This is I will not elaborate too much more because I'm a bit short of time, but just briefly, adaptation requires healthy variation. You need to have some flexibility in order to be to be able to adapt to a given context, because context will eventually change. If context remains the same, you can keep on doing what you're doing if it gets you to the desirable outcome. But once it changes, most likely there is flexibility required that then requires you to choose another option, select another option, and then retain that new option in order to move toward the desirable goal. Similar to choosing the right keys to enter, to open the door to get to where you need to go. This really ties us directly to Darwin, who the principles that psychopathology is, in this case, maladaptation, and due to problems in variation, selection, retention in a given context. If you want to know more how evolutionary science can possibly be tied to clinical science, I invite you to read one of our special issues that we put together with David Sloan Wilson, an evolutionary biologist. Putting this all together, by the way, we have now already enough to come up with an alternative system to the DSM. And we would say that there are different dimensions that we're looking at, similar to RDoC, different systems of the self, of cognition, attention, affect, behavior, motivation, social, cultural, biopsychosocial. Again, these are not independent, they are networked together, but for simplicity's sake, I'm listing them as separate dimensions. Individuals might have problems in variation, selection, and or retention in on those different domains or dimensions in a given context. Context is core to understanding psychopathology, because I would argue any behavior is actually quite adaptive if you create the right context for it. There's hard to imagine what couldn't be adaptive. I'll come to my summary. What we really need to do is kind of think hard about our clinical science. We need to have a fresh new look at what we're doing. We shouldn't be continuing on the path that we have embarked on. So we need to break down traditions, different schools, different waves, and we argue that we could go back to our origin, to Gordon Paul, and we would argue that we look at the biopsychosocial process that we need to target. Once we understand these processes, we can effectively target problems of an individual. We need to go back to the individual. There is obviously there's room and there's a reason why we want to study groups, but only studying groups will not tell us much about how to treat best a single individual. We think that the model of marvelous evolutionary science that has not gotten a lot of traction in our field, and I think it might be time to also think of ways how we can integrate that. I think it goes back to functional analysis. A network approach is in a way a blown up version of functional analysis, where we're trying to understand how problems are interconnected. Once we understand these interconnections, then we can appropriately intervene. And on that note, I'd like to end my presentation and looking forward to a fruitful discussion. Thank you very much for your attention.
Fantastic. Thank you so much, Stefan. And I believe that we have Dr. Francis ready to go. I think he's in disguise as Donna Manning here, I believe. Let me see. And you might want to take a look, Dr. Hofmann, in the chat. There was someone who had a question for you there, and we could save it for the Q&A, but if you want to address it now, that would work too.
Let's see. Let's see. What are your thoughts regarding high-top model? So high-top is obviously another attempt for a new way of classifying or a new way of understanding psychopathology. The positive features are that it's looking at dimensions. The really clearly negative aspect is that is completely tied to a nomothetic approach. We are using massive amounts of self-report data, assuming that whatever is true for the group should be true for a single individual, and then constructing this very complicated system around it in order to understand how these dimensions link now to DSM-defined psychopathology. So you heard maybe between the lines, I don't think much of HiTOP at all, because it doesn't really solve the problem that we are facing.
Okay, great. And I want to encourage folks too, as we go along, to please put any questions into the chat box if you have them. We have reserved plenty of time at the end to for Q&A. So okay, and but let me see if we can transition to Dr. Francis here. Are you with us?
Yes, I am.
Dr. Francis. All right, fantastic. Yep, we can hear you just great. And but don't start just yet, because I want to make sure that I give you a worthy introduction here. Okay, so let me for those of you who are not familiar with Dr. Francis, he actually has a Wikipedia page, so I'm going to steal from the Wikipedia page here. So he's psychiatrist, currently professor, chairman emeritus at Department of Psychiatry and Behavioral Sciences at Duke, best known for serving as chair of the American Psychiatric Association Task Force overseeing the development and revision of the DSM-4, although I think it was actually DSM-5, or well, you can correct me if need be there. Founding editor of two well-known psychiatric journals, Journal of Personality Disorders, Journal of Psychiatric Practice. Let's see.
It's enough. Let's go.
All right. Okay. All right.
Okay.
Well, the floor is yours, Dr. Francis. We'll catch up with you on the other side.
It's okay that Donna Manning's listed. She's the brains of the operation, my wife. I have very warm feelings about Arizona State. Your colleague, Joanne Cacciatore, is one of my favorite people in the entire world and the world's expert on grief. And Bobby Hurley was once in my lap for about a second. I was a great Duke fan, and part of my recruitment to Duke was to have front row seats for 1 year. And he landed in my lap on one play, and that was a highlight of my life. And I can vividly remember him at the UNC game when we won it, screaming at Grant Hill, "You the man," and Grant Hill screaming back, "No, you the man." So Arizona State is a place that I feel close to. We're going to tackle three topics. The first is the shameful neglect of the severely ill. Their complete lack of access. It's a topic that is central to your efforts, and I have very strong feelings about. The second and related topic is that we've been way overdiagnosing people with mild illnesses or problems of everyday life, the distress of living, and giving them way too much medication. These two topics I know a lot about. The third topic, which I haven't written or talked about, and I know almost nothing about, is there really an increase in the rate of psychopathology occurring, particularly among young people now? Are there rapidly increasing rates of reported anxiety, depression, eating disorder,
Yeah, he is in Red Wing.
ADHD? Are these all related to a change in actual rates of disorder?
Yeah, so
becoming
Joe
a
is in
sicker
Red
and
Wing
sicker
for a
society?
year. He's been there for a month.
Or instead is just a matter of labeling?
But apparently he likes it.
There is someone talking.
He says the
If
first
we-
day. And they get to play ball, but yeah.
Yeah, if we could ask
And
everyone to
then
please
the
mute yourselves.
Adoption medicine clinic can make exceptions.
I think I located the person here, muted them.
Okay.
All right.
The first and most important topic. Up until the 19th century, the mentally ill maybe 18th century. The mentally ill mostly lived in rural areas, and it was manageable. With the tremendous urbanization that occurred in the 1700s and 1800s, with people moving into the cities, there was no place to keep the mentally ill, no one to care for them. Very often, father and mother were both working in factories. They got lost in the shuffle. What happened to them? They wound up homeless and they wound up in prisons. The great reform that occurred, starting with Pinel in France and extending around the world, and particularly in the 19th century in the US, was the idea of asylums, safe places for the mentally ill, where they wouldn't be put in jail, where they wouldn't be forced to live on the street. This was a wonderful reformation. The state hospitals that were built, if you visit them, were among the most beautiful buildings in America. And they were self-sustaining. The patients had work in the hospital. Basically, they had dignity, much more than they had before. And this was a seemingly fairly good solution. The trouble was the cities grew bigger and bigger, the number of patients more and more. The budgets to build new hospitals no longer present, and the hospitals started getting more and more crowded. Some hospitals in New York had 25,000 patients, if you can imagine that. As they became overcrowded, they were no longer hospitals, they were warehouses. I worked in such places. They were horrible. They were impossible to live in, very, very difficult to work in. In the 50s, there was a foundational book and then movie called The Snake Pit. Journalists went underground in the hospital, described how horrible it was. Another important change at that point was the beginning development of drugs that would help people, not so much in their fundamental illnesses, but help them at least in the symptom presentations. And the third thing that happened late in the 50s, and then especially with John Kennedy's election in 1960, was a government interest in a new model for treating the mentally ill that would take it away from the state hospital. The Kennedys had lobotomized the sister. They felt terrible about it. And they saw mental health as a major area where they could help change the country for the better. What had been in the works before, a community mental health program, was approved by them. And the idea was that now that we have these wonderful new drugs, now that we have the capacity to understand that the mentally ill can function in communities if we provide them with housing, and now that the state budgets are so stretched in caring for the mentally ill in these horrible warehouses, in every state, the biggest budget item was the mental hospital. The mental health budget was the biggest state item. Why don't we have a system that's going to be more cost effective and more clinically meaningful and more appropriate to the civil rights and the dignity of patients? We'll take them out of these horrible warehouses, have them on medication, treat them in community mental health centers, and provide decent housing in the community. It was a great idea, and it was working. What happened? The Reagan administration in 1980 did many things that were horrible. Among them, and among the first of these things, was to change the funding of the community mental health centers to no longer earmark the dollars so they would specifically be spent on community services. Instead, to give them to the states as block grants. The states immediately offloaded the responsibility for the hospitals. So they dumped the patients on the community with horrible consequences, and I saw some of that myself. They closed the hospitals. They did not provide the community care that was necessary to take care of the patients. What happened to the patients? We went back to the 16th, 17th, 18th centuries. The patients wound up in prison on the streets. It's a horrible shame. We once had about 650, 700,000 beds. They were not, beds that would be providing great treatment or a great place to live, but at least they were beds. We now have about 35 or 40,000. We've closed about 90% of the beds. The patients, the 600,000 patients who might have been in hospitals, are now that exact number in prisons or homeless. And if you've ever visited a prison, there is no worse place. I've been to state hospitals and I've been to prisons. The prisons are far worse than the state hospitals were, bad as they were. You walk from cell to cell and you see people who are just smearing excrement all over the walls. They have no way of expressing themselves. If you want to drive someone crazy, There's no better way to do it than put them in solitary confinement. And that's exactly what we do in our prison system. We keep them a long time. We put them in solitary confinement. Often they're there because there was no place else for the cop to take them. The cop knows that if he goes to an emergency room, he'll be kept there for 6 hours or longer. At the end of the day, there'll be no disposition. The patient may at best get an appointment in a month. The cops have learned that if a patient is a nuisance on the street, the best thing they can do is arrest them rather than bring them to the hospital. Why do we have so many shootings? Part of the reason why cops are so quick on the draw is they're scared silly about the patients who are unpredictable, who they may be. See, 1/3 of the cops' work these days is responding to calls related to the mentally ill. 1/3 of the prison cells are occupied by the mentally ill. There is no worse shame in this country. No one cares. When the Biden administration, which has been wonderful in so many ways, came up with an infrastructure plan to improve America, guess what? They did not even think about including an infrastructure improvement for the mentally ill. That's how far away their concerns. This is not a constituency anyone cares about at this point. It's a great tragedy to the patients. It's a great societal cost. It's a lot cheaper to keep people in the community with adequate mental health care and adequate housing than it is to have them going to the emergency room constantly or to be in much more expensive prisons. So that's the major message of what I'd like to leave with you, that whatever we as a professions have been derelict. It's not been the #1 item on the agenda of any of the mental health professions. All of them have lobbying arms in Washington. All of them lobby to some degree for the severely ill. None of them have made it the major priority, and it should be. Second part of the talk, while we're neglecting the severely ill, we're over-treating the mildly ill. And in the US, about 20% of people are taking a psychotropic drug because we have an overly loose diagnostic standard and because psychepidemiology is inherently biased. All of the studies in epidemiology are telephone. None of them have a clinical check. Too expensive. If you're doing large-scale studies, it's too expensive to make sure that the patients who are described as having symptoms are also clinically enough distressed or impaired in their functioning to require a diagnosis. The numbers reported are ridiculous. Something like 25% of patients would get a diagnosis in the previous year, according to epidemiological studies. The drug companies have jumped on this. The drug companies have jumped on an excessively loose system. And until fairly recently, they jumped on their ability to advertise psychiatric drugs to the consumers directly. And so we have a situation in which 20% of the population in the US is on a psychotropic drug, a ridiculously high number. So at the same time that we have way too little access for treatments for the severely ill have a great deal of trouble getting the drugs, which almost all of them desperately need. Simultaneously, we have almost too much access to drugs in the mildly ill or normally distressed. Where do these drugs come from? 80% of them come from primary care doctors, not from mental health professionals. And the general time frame in this is that the doctor sees the patient for about 10 to 15 minutes. They have very large panels of patients. They don't know their patients well. They usually don't know the medications very well. They, in the past, were heavily influenced by the detail people, the salespeople who would come to their offices and promise miracles if patients were on drugs. And so the easiest way to get a patient out of the office happy in 10 or 15 minutes is to write a prescription. And that's exactly what most primary care doctors do when patients come in with emotional distress. And since a very large percentage of patients come in with emotional distress, we have the situation in which 20% of the population is on a psychotropic drug. And these psychotropic drugs are a varying degree of possible harm. One of the most commonly prescribed class, the benzodiazepines, are almost not necessary in psychiatry, and yet still very heavily prescribed, very harmful, very prone to addiction, very hard to withdraw from. So we have this horrible, cruel paradox of too much access to drugs in the group of people who least need them, almost no access to needed medication and adequate housing in the people who most need them. The third part of the talk is the issue of the amazingly fast rising rates of reported distress and symptoms over the course of the last 30 years. And what does it mean? Now, I had written a lot about the rapidly increasing rate of attention deficit disorder, autistic disorder, and bipolar disorder. And I feel I'm fairly comfortable ground in these three areas, so I'll do that first. Most of the rise in rates was a difference in the way patients were assigned diagnoses, not in an increase in symptoms. So we know this for absolute sure for ADHD. There have been in about a dozen countries studies with, I think it's about 15 million people, kids. And it turns out that in country after country, in these enormous samples, the best predictor of whether a kid gets a diagnosis of ADHD is his birth date. The kids who are youngest in the class are almost twice as likely to get the diagnosis of ADHD as the kids who are oldest in the class. It means that immaturity is being misinterpreted as mental disorder. There's no way of explaining this. This is one of the most robust findings in all of psychiatry, psychology, and there's no way of explaining it except overdiagnosis of young kids as having mental disorder, because they're the least disciplined in the class that may lack discipline. The teacher says that this is the kid who's causing you trouble. That kid gets the diagnosis. We're turning normal immaturity into a mental disorder. Does this mean that there were no people who were previously missed who were now identified accurately? Of course not. So as ADHD became a popular source of advertisement, as it became a popular source of explanation for why kids weren't doing well in school, perfectionistic parents saw ADHD as the explanation for poor grades. There was a tendency to see it in appropriate places sometimes, but in inappropriate places very often. What's the true rate of ADHD? There's no way of determining a true rate of any mental disorder, that these are all constructs. And the definitions should be based mostly on utilitarian factors. We can't say what's the gold standard for a rate for ADHD. We can say what is probably the most useful rate, definition and application of a definition that would produce a rate that would cause the most benefit and the least harm. The father of ADHD was Keith Connors. He'd done one of the original studies in the use of medication for ADHD in the 60s, even before there was a diagnosis of ADHD. He was very important in all of the subsequent studies that were done, very important in the definition of the disorder. Keith died an unhappy man because he felt that ADHD had been wildly overdiagnosed, and the overdiagnosis was causing more harm than good. It was his belief, based on experience and the studies he and other people had conducted, that the best rate of ADHD in the general population of kids would be about 2 or 3%. It's now 11%. And he felt that this was a way overshoot, that the medications were being way over promoted. He had done a study showing that medication was much better than behavior therapy for ADHD. But 2 years later, when he did a follow-up study, and with subsequent follow-up studies, he found that the medication did not improve academic performance. It had short-term benefits in terms of focusing without long-term benefits in academic performance. And he felt that, again, this was a reason that we should not be prescribing the stimulant drugs as much as they were being prescribed. We blew this in DSM-4. We rejected 92 out of 94 new diagnoses. We were very conservative in DSM-4. It's almost exactly like its predecessor. In ADHD, we made a very slight change that would make it easier for girls to get the diagnosis, but in careful field trials, it seemed that would increase the rate only by 15%. Instead, the rate quickly doubled and quadrupled, then tripled, and now almost quadrupled. Why did this happen? A lot of it had to do with drug company marketing. That in 1997, two things happened. The drug companies changed very slightly the formulations of their medications, but that gave them patent protection. And pills that were previously pennies a pill became dollars and sometimes tens of dollars a pill. And they were able then to have the means, and the FDA then gave them the method to advertise broadly. The FDA in '97 made it much easier for drug companies to advertise directly to consumers. Pretty soon, every magazine, TV ads filled with stuff about a magical cure for attention deficit. And now the stimulant pills have become the favorite drugs on campus, both for performance enhancement and for recreation. There's a secondary market with 30% of kids in college campuses, almost as much in high school campuses, using stimulant drugs that were prescribed and then illegally sold into the secondary market. I think it's pretty clear that ADHD is very overdone. Similarly with autism, the one change that we made was to include a diagnosis of Asperger's, which subsequently in DSM-5 became autistic spectrum. And the reason for this was that, as previously defined, autism was, get this, it was diagnosed only 1 in every 2,000 to 5,000 kids. It was that rare. If you take classic autism, it would be 1 in 2,000 to 1 in 5,000 kids. The pediatricians felt that and child psychiatrists felt that they were seeing many kids who needed help, needed school services. They needed to be in special classes in school, but could not be diagnosed with a definite autism diagnosis because they didn't meet the classic criteria. We set up a set of new criteria for these, called it Asperger's, and did a careful field trial, and it seemed that it would triple the rate of autism. And so that seemed reasonable. Again, we did not anticipate the fact that the new criteria would change the world. And very quickly, instead of that rate of 1 in 2,000, the rate of autism jumped to 1 in 200, then 1 in 130. Now it's about 1 in 35, 1 in 40. And the reason for the enormous jump was that every form of childhood problem quickly became autism, and that the milder forms of social interaction problems that previously would have been accepted as normal nerdiness became a mental disorder diagnosis. And there was almost a chic associated with having an autistic diagnosis. And all this was much worsened by the fraudulent publication in The Lancet in 1997 of a paper that said that vaccination caused autism. It turned out that paper was fraudulent, consciously fraudulent. It was withdrawn by The Lancet. The doctor who published it has lost his license, but it's still widely believed that the reason for this high rate of autism is vaccination. And it became a very popular diagnosis, partly because the anti-vax people seized upon it as part of the argument against vaccination. In these two instances, I have absolutely no doubt that the increased rates, and these were enormous exponential jumps in rates, were caused by a change in the way patients saw themselves and were assessed by clinicians, not by a change in their actual level of pathology. It wasn't that people suddenly got to be more attention deficit vulnerable or autistic vulnerable. It was that we were redefining what was previously a distress that might have been considered normal or considered diagnosable under another rubric, redefining it by these new popular fad diagnoses. The history of medicine, the history of psychiatry is characterized, littered by fad diagnoses. This has been something that goes back thousands of years, and it's very easy for DSM, especially if there's an external reward to a diagnosis, to lead to fad diagnoses. More difficult for me to understand, and I haven't really, I don't have evidence, I don't think anyone does, and I haven't thought about it deeply enough to really feel confident to say anything, is why are the rates of suicide going up, particularly among teenagers? Why are the rates of reported anxiety and depression going up so rapidly? And particularly, why are the rates of eating disorders going up so rapidly? It seems like almost every girl these days. Are you finding this out in Arizona State, the tremendous increase in the rates of eating disorder, especially among girls? I don't know. I used to be prepared to think about these things as our fault, as a labeling problem. But it is conceived. My argument was that human beings don't change that much, that human nature is pretty stable, but assessment methods can change on a dime. It's the easiest thing in the world to change the way we see people. It's harder for those people to change in their basic natures. But are the screens changing the way kids act, see the world, experience themselves? You know, is this an experiment in nature, having kids spend so much time in front of a screen and not with other kids? That really does basically change to some degree human nature, the way they experience themselves. Parental patterns have changed so dramatically. So I grew up with children were supposed to be seen, not heard, and I was spanked when I was a kid. Now everything a kid does is good job. Does that make them more disruptive in classrooms? And is that being misinterpreted as a mental disorder? I'm not sure. I mean, I think that I used to have this strong feeling it was our fault that we made the labeling too easy. But could there be real trends that make the people now in some ways different than people used to be, not just in the way they see themselves or are labeled by us? Not sure about that. I think in terms of accessibility, and I really much enjoyed Dr. Hofmann's talk, and I hope we have a chance for back and forth. I think that the best thing in terms of accessibility recently has been the availability of teletherapy. I see that as a tremendous addition to reduce the obstacles that people have to get therapy. I think texting is wonderful. I think texting will be more and more a valuable way of keeping in close contact with patients in a way that's very time efficient for patients and time efficient for us. I wrote an article recently, will we be replaced by computers? It's happening already. There are about 10,000 apps, many of them in some ways replacing us, some of them totally replacing us. And my conclusion in the paper was that computers can do everything we can do better. And there's no reason that won't be true for psychotherapy as well, but probably it will be slower for psychotherapy than it will be for most things. So I think that we will have an edge over computers longer than coders have an edge or lawyers have an edge, but eventually I think computers will be increasingly replacing us. And if you're interested in that, there's an interesting history to that. A fascinating point. My granddaughter was visiting and we asked the computer the same question. We asked ChatGPT the question, will computers replace therapists? It was very modest in its answer, very careful not to step on toes, but it gave a brilliant answer. And recently, whenever I do a blog, I check with ChatGPT to see what they say, and it's getting better and better. I'm still slightly better, I think, but not much. The gulf between me and ChatGPT in writing a blog is narrowing every month. So I imagine that will increase access to patients, but it may also eliminate the patients because we're playing a dangerous game here. Another point that Dr. Hofmann brought up was the network complexity, and I agree completely with him on that issue. The only place we might disagree is, I think, as the network complexity becomes so complex, it no longer becomes a research question. It's more a clinical patient to therapist question. It's harder, the more you add the reality of the, it's like Borges with maps. If you want to have a map of the entire world, you'd have to have something the size of the entire world. The more we build in the complexity of each individual psychotherapy interaction, the more complex that becomes, the less it becomes a research question because it gets just so complex. In terms of cognitive behavior therapy, I recently coincidentally had a contact with Judy Beck. And Judy Beck right now, the way she does psychotherapy, she includes every conceivable technique, including psychodynamic. That my view on this is that we should get rid of this alphabet soup of there are 50 or more psychotherapies labeled, and we should be teaching psychotherapy, and that every competent clinician should learn all the techniques that were mentioned in Dr. Hofmann's talks and some more, especially techniques that focus on bringing the past into the present and techniques that focus into producing corrective emotional, bringing feeling more into the menu, into corrective emotional experiences and so forth. But I would say that the various schools of often competing, but really complementary schools of psychotherapy should be merged. We should see psychotherapy as just one thing. But that's enough for now, and I really appreciate the chance to be with colleagues from Arizona State. Thank you.
Thank you. That was fantastic. And I really want to, compliment you on your courage for, speaking out against your own guild. But actually I have a question related to that too, for both you and Dr. Hofmann. But before I get into that, I want to encourage people. We did build in plenty of time here for Q&A. I mean, the event is scheduled for 5:30. It's to end at 5:30 Eastern time. It's not a hard time either. We can flex that. But if you have questions, comments, you want to put it into the chat box, feel free to do that. This is your opportunity to hear from these two great experts. But to get us started on that, there was a talk, or I'm sorry, there was a question here that you responded to in the chat, Dr. Hofmann, from Jeff Goody, and I don't know if you wanted to. I didn't actually read it, so I didn't know if that's something for the whole audience that might be worth talking a little bit about.
Yes, I think so. Jeff Goody, who's also a colleague and friend from ABCT, I know him pretty well. So his remark is on the theoretical philosophies of the various psychotherapy. We have lots of different schools of psychotherapy. Of CBT, we have then within the third wave movement is as there's ACT, there's mindfulness-based stuff, there's schema therapy, contextual stuff. Then there's the psychodynamics and so forth. So I think one of the, Steve and I, we came from different directions. I'm a much more traditional CBT person, and Steve has been sort of rather oppositional to traditional CBT. And we kind of connected at these points of where we said, where are we? What do we really want? We're obviously fighting with one another, and is it really meaningful to fight? We used to have these kind of academic wrestling matches where people invited us on stage to debate each other, and it became a little ridiculous. So we thought, what is it that we actually disagree on? What is it that we want? And so clearly, we wanted to advance the field of science, and with these differences are minuscule between the different orientations. As Dr. Francis suggested, we should get rid of these fictitious walls that we're putting up on ourselves. And if you want to become a famous psychotherapist, you name yourself a new school of therapy, put your Wikipedia page up, and you do workshops and write books, and then you are. But this is not a good model to this, and we repeat the very similar thoughts over and over again and again. If you look at these strategies that we're actually implementing, they're very similar in the various different traditions. So I think one way forward, that also Steve and I thought, is breaking down these walls. What we need to have, obviously, theoretical, scientifically testable theories, and the processes that we are discussing, they are both psychopathology processes and they are treatment processes, and we need to disentangle those, and we need to also move toward understanding them. That we're way too simplistic in analyzing processes, way too. If we compare, I mean, there's nothing wrong with tackling complex issues, but we don't need to give up and say we're just going to rely on a very overly simplistic model and claim that everything can be reduced to one single idea. That's nonsense, obviously, right? Einstein once said, every complicated problem should be as simple as possible, but not simpler. So obviously we need to have a level of complexity that is meaningful. I agree with you. Network analysis can easily get us into a jungle where we don't know the way out. But I believe that there's also a way to embrace complexity and making the science more meaningful, and tied also to clinical wisdom, that we don't just operate completely separate from what's being done in clinical practice, and that we don't care what clinicians do. Scientists need to listen to clinicians, look at them very carefully, and then understand those processes.
And both of you made a reference as well to kind of the protocol-driven care, that exists out there. And since this virtual series is focused on access issues, that's something that I see getting in the way of access actually quite a lot, because these modular kind of protocol-driven approaches are put through a randomized controlled trial. They're demonstrated to be effective, which is wonderful. But very few people end up actually getting trained in these protocols. And so, kind of word gets out about these gold standard protocols that are out there. And in the world that I work in, I train clinicians to work in primary care. People come into primary care, they have a condition that maybe the clinician has read about, that there exists this sort of gold standard protocol out there, for treating this problem. And so, but they haven't been trained in it themselves. And so they back away from even trying to engage with the patient and, refer them into the ether, basically, trying to find someone who can deliver this gold standard protocol. So these protocols really actually get in the way of access, from my angle too. So we had another comment here too from Becky Johnston.
Can I just comment on that?
Yeah.
I was on the NIMH committee that did the funding for psychotherapy studies in the 80s. And because we had to follow rules of the game that were set by clinical research trial methodology, otherwise NIMH would not give us the money, there was a requirement that the treatments be given in a standard manualized form that was reproducible. Otherwise, you wouldn't be able to interpret the results. That would be seen as a fatal flaw. Why spend money on this? Again, both Tim Beck and Judy Beck, they were very clear, in Judy's case, that the reason for the manual was the research projects. They couldn't get funding except if they had a manual. They never wanted anyone to do therapy via the manual. They don't treat via the manual. You can't treat patients via the manual because you'll always be missing what the patient really is saying and needs at that moment. So I think that the whole idea of manualizing was meant as a research more than a clinical tool. The idea that you would manualize for every diagnosis and that you would do it for the 50 alphabet soup therapies is absolutely nutty. It's bad for patients. It's terrible for training. So I think it would be much better if every training program in the country, including yours, said, we don't teach a manualized form of this or that kind of therapy for this or that kind of problem. We teach psychotherapy techniques. We enrich the toolkit of people who are in our program so that they can meet the needs of different patients, not be hammers looking for nails that sort of force the patient to be in a particular category in order to get the manualized treatment.
Yeah, I couldn't agree more. If I could also add just one sentence, I couldn't agree more. And I think that is also sort of closely tied to RCTs, right? To randomized controlled trials, where we conform groups of people sharing the same psychopathology and then using and comparing them to another group, and then we're using the treatment manual to test that. And RCTs have a role. It's not to say that RCTs are not, are garbage. They have a role, but they don't tell us some very important things, such as processes of change. We really don't know much using RCTs how the treatment works. We just know that it works and how well it works as for this group as compared to that group. RCTs usually, vary one single variable. We randomize them based on that, but we need other methods to study therapeutic processes, and that we are really way behind the 8 ball on that.
Yeah, and let me just make clear that the value of the RCTs is not just theoretical. The reason that you're getting paid by insurance companies, the reason why many national health plans will now pay for therapy, whereas they wouldn't have paid for therapy 30 years ago, is because the RCTs demonstrated efficacy.
Yeah.
And the most valuable RCT, the only valuable RCTs, have been the ones comparing psychotherapy to drugs and determining that for mild to moderate problems, psychotherapy is just as effective. The RCTs that compare two psychotherapies, the whole literature is basically worthless because it's all tie scores. And the amazing thing about that is that Saul Rosenzweig in 1936, if you haven't read his paper, dig it out and read it. In 1936, he wrote a paper that essentially said, based on Lewis Carroll and his intuition, that all the therapies will run and they will all win and there'll be lots of tie scores. And he explained exactly why, because the non-specific aspects of psychotherapy are so much more important for most patients, not all, than the specific aspects. So that the most important studies to date have been RCT studies that got all of the compensation for therapy official, both for insurance companies and national governments. But that doesn't mean that they have much to say, if anything to say, about how to treat an individual patient. And that the methods used in the RCTs are antithetical to good therapy with the individual patient.
Yeah, the other problem with these protocol-driven approaches is that they're not really population-based at all either, right? And so the one piece of data that is perhaps the most important piece of data that comes from these RCTs is what was the uptake of these protocols by patients to begin with in the population, right? It's one thing to show that a treatment is effective. It's another thing to show that people will actually agree to participate in it on a large scale, right? And that next to never gets presented. So we developed these, sort of gold standard protocols, in the lab, but it doesn't really translate into a very helpful approach at the population level.
Yeah, I'd like to kind of summarize and always what I'd like to say in one sentence. We are not treating psychopathology, we're treating patients, we're treating the individual. And and we need to understand the problems of the individual to be effective. So for that reason, the move is sort of toward, we call it sometimes precision medicine or personalization. And every good clinician does that. Nobody hangs. Only the junior people, they follow treatment protocols. An experienced clinician doesn't really care much about a manual. They approach the individual, how they and understands the individual, looks at the world from their perspective and trying to understand why the problem is maintained and how to solve it.
The other thing related, when you speak to really terrific clinicians from any of the schools, or you see them do therapy,
very similar, right?
They're remarkably alike.
Yeah.
And I think that you can really make potentially good therapists, terrible therapists, by training them to protocols. So you can take people who would naturally be gifted, flexible, interpersonally sensitive, and if you train them enough with protocols, you can make them into pretty terrible therapists.
And it's so true. Yes, I see that all the time. Let me shift gears here for a moment and get to a question that we have from Becky Johnston. I think we have someone who needs to be
she didn't
muted.
tell me that.
Hold on just a moment here.
Yeah.
All right, there we go. So the question is, I work for an insurer. Reimbursement for therapy is tethered to the DSM diagnosis and ICD codes. How do you envision payers adapt their approach to reimbursement to be more tied to individual treatment needs rather than tying reimbursement to a label?
Yeah, actually, I've
I've
worked with some insurance companies on this. It's an absolute disaster that insurance companies require a diagnosis before payment for evaluation visits. What this leads to is jumping to a diagnosis way before you should. I love this expression, diagnoses should be written in pencil. Always we should be under-diagnosing because it's very easy to then upgrade the diagnosis, very hard to take it back. Once a person gets a diagnosis, they're often haunted by it for life. And often enough, the diagnoses that are made quickly are wrong. Most diagnoses are made by primary care docs in 15 minutes. I think that the world would be a lot better if insurance companies would pay for 5 evaluation visits or 10 evaluation visits. The world would be a lot better if brief therapy were free. If you made brief therapy completely free, most people want brief therapy. Brief therapy is very helpful for most problems. If you made that free, you'd be saving money in the long run, because what happens now is the clinician has to make a diagnosis in 10 minutes. They have to diagnose a DSM disorder. They feel to get the patient out of the office, they have to begin medication. And very often the patient will be, because placebo effects are so powerful, very often patients will be on medication for years, decades, sometimes lifetime, that they didn't need. Very expensive to be doing all that treatment for a very prolonged period of time. Much of it would have been avoided. Many people come to a doctor, psychologist on the worst day of their life. If you just allow time, regression to the mean, understanding, a little advice, the placebo effect of a relationship, most of those people are not going to need any further treatment. And instead, we rigidly put a diagnosis on, often incorrect diagnostic label on them early in the game, often stick them with a treatment they may not need that will be harmful to them, and then make it very hard to reverse either. Medicines are very hard to withdraw. The diagnosis often sticks and haunts. So the whole system would be smarter, cost-effective, it would be cheaper if we had more flexibility at the beginning.
I love that. After all, the modal number of visits is with a therapist is 1, right? To your point, most people want brief therapy. Let's see, there's another question / comment here, if I might join the discussion. While it seems to me that the theoretical variety we have is not very helpful, I think social psychology has pointed out clearly how prone we as humans are to cognitive errors in our thinking. One thing that theory does for us is gives us a basis beyond our own biases for understanding the data we collect and even the questions we ask. And that question was directed to you, Dr. Hofmann, if you have any thoughts on that, but Dr. Francis, feel free to jump in too.
Yeah, certainly. I think we theories are that you know, we always have predictions about the world, but we never we don't live in a theory-free world. So certainly clinicians will have a theory of a client, and the theories of the client is tied to their traditions. What I think is important though is to not be confined by that, to not be to not treat it as a religious sort of idea that you can't step away on outside, and you need to, number one, always consider that you're wrong with what you assume, and then broaden that the view. You know, just as a psychodynamic therapist, they might want to also consider, you know, cognitive errors and behavioral contingencies. And a behavioral cognitive behavioral therapist, a good behavioral therapist, does it already, and Tim Beck certainly did this, is also looking at past experiences, relationship aspects that factor in. But the thing is, it's not true for every client. People are different, and for some people, the upbringing is very important. For others, it's not that terribly important. And some are more resilient than others, and a good clinician knows which factors are more relevant for a given individual than others, and that's what makes then a good therapy a good therapy.
Yeah, I always say to people, you learn from your patients. You don't even listen to me. People I supervise, don't listen to me, because whatever ideas we share today will be out of date by the next session you have. You need to be in the room with the individual, and it's exactly what Stephen was saying, that the therapy is one of the more idiographic things in the entire world, because of the complexity of each person, the complexity of the networking between them. It's impossible to predict what will be best the next moment. It's the one thing we have left, I think, before AI catches up with us, is intuition about what other people need at a given moment, what they're feeling and thinking. And that should be that should be written in pencil. That should be very flexible. That should be moment by moment.
So we have a question here. The question is about value-based care. How do we envision value-based care affecting the future of mental behavioral health? Does that connect to this topic in either of your views? And if so, how?
Well, I personally think absolutely that so we are too focused on reducing DSM symptoms when people come in, and this is how people are trained, and what is the diagnosis. We're targeting that, and especially if you're in research studies, which I've done many of those, you're kind of hyper focused on syndromes, but sometimes that is not the main concern that the patient has. They might come in with a diagnosis, but they will have, their generalized, their worrying generalized anxiety. So certainly this is an issue, but more of an issue is what they want to do with their lives, or the partnership, or some other issues that are much more relevant. So we have to be mindful of that. We're not treating those syndromes. We have to listen to where people want to go, and sometimes you have to go through some rough times in order to reach where you want to end up.
I think that the crying need, both morally, clinically, and also economically, for value-based care, the crying need is to take care of the people with severe psychiatric disorder who are sleeping rough on the street, or sleeping in prison dungeons. That's a shame to our society. It's economically foolish. Prisons are terrifically expensive. Even being homeless is a great societal expense. And the best value-based care we could do at this moment is to be closing prison beds and opening outpatient psychiatry units and more psychiatry beds. I think that it's wasteful, and we said before, that 20% of our population are getting psychotropic drugs because we don't spend enough time in having them evaluated properly at the beginning to make sure they need them. It shouldn't be a 20-minute, 10-minute visit with a primary care doctor. So I think that if this were a rational system, we would be apportioning resources very differently than we have. Unfortunately, our system, you're better off in Germany. Our system in America is a private model, a capitalist model that favors profit over individual patient care. That's not rationally, the resources are not rationally apportioned to the needs of patients. They're apportioned to the needs of the people who are earning money based on providing care to patients. And it's a lot more profitable to treat people who don't need help. The most expensive patients to treat are the ones who most need treatment.
And I think that is also true. Obviously, as you mentioned, the prison system needs to be rethought, and it's a tragedy also to put mentally ill people on death row.
So that's getting us into the realm of which you all have been, talking about at various points throughout the last hour and a half, as well, about systems issues. We can maybe wrap it up on, unless another question comes into the chat box, we can wrap it up on this question. I'm interested to hear from both of you. Both of you are really challenging your own guilds, right? To really in ways that are have economic consequences in addition to other sorts of consequences. I mean, in your case, Dr. Hofmann, process-based therapy is potentially simplifying therapy to where it can well, it's just a lot less complicated than people who are invested in who have been invested in developing sort of the theoretical models that are much more complicated around cognitive behavior therapy and that sort of a thing. So that is on your end of the field. That's one thing that kind of puts you at odds potentially with your guild. And then of course on your end, Dr. Francis, you're challenging the very basis of psychiatry, right, with challenging the notion of the nature of mental health and overdiagnosis and so forth. So how do we get past the point that our guilds have a real investment in keeping things the way that they are, right? And just how do we get around that?
Should I take it first? Well, I don't think, I mean, I was trained with Tim Beck, and he taught us and me that critical thinking is essential. Critical thinking is really at the core of cognitive therapy. So I don't perceive it as challenging my guilt. In fact, if anything, I see that tradition of Beck's being carried forward, and he was aware of the early beginnings of process-based therapy, and he was tapping me on my shoulder and said, go for it. This is the way to go forward with that. So no, I don't feel like I'm sort of an abnormality in CBT. In fact, I think this is sort of along the tradition.
I think I have challenged my guild and failed, and it's not just my guild. It's not just psychiatry. It's psychology, it's social work, it's all of the mental health disciplines have been essentially enabling of the tragedy of the severely ill being in terrible circumstances. The patients have been too. So there was a tremendous enthusiasm 45, 50 years ago as patient activists began forming patient advocacy groups. They've largely been co-opted by drug companies. A good part of their budget comes from drug companies, and they much more advocate for the access to psychotropic drugs for people who may not need them. They don't advocate very strongly for getting patients out of prison or giving them homes to live in. So I'm very pessimistic. I think we've seen 50 years now of absolute disasters, irrationality in the way we deliver mental health or don't deliver mental health care. And even the Biden administration, which was, like one would hope, the most enlightened of administrations in my lifetime, even the Biden administration, when they're thinking about infrastructure, how could you not look at America and think, oh, maybe we should have more community mental health centers. Maybe we should do more housing for the mentally ill. How could you ignore that? Especially when every day there's a story about a homeless person causing a crime or being a victim of a crime. And when the prisons are filled, when the sheriffs are the best advocates for better mental health care in America are the sheriffs, because they're the ones who have to deal with the untreated patients on the street. One last thing I'll close with. In countries that have good care, Germany being one of them, the patients look different. The way we see our sick patients is not the way they are. We've made them much sicker. When they're treated well, it looks like a completely different population of patients. If you travel the world, you're amazed at how people can be handled so much better, their symptoms so much less, their capacity to function in responsible jobs so much more, partly because they haven't been made sick by our system. Our system is not neutral, it's harm producing.
It's actually a great way, a great sort of message to send us out on, I think. It's kind of what we're trying to get at, I think, with our whole virtual series here, is just the various ways that our system really is getting in the way of itself in terms of making it harder for us, for people to be well. So I have not seen any other questions or comments in the chat box, and it is a little bit after 5:30. So I want to thank everybody for attending, and obviously thank Dr. Francis, Dr. Hofmann, for sharing your time with us, volunteering your time with us. This was